hemoglobinopathies, diagnostic tests, HPLC, and interesting cases. Our faculties are Dr. Ruchi Gupta, Additional Professor, Department of Hematology, SGPGI, Lucknow, and Dr. Dinesh Chandra, Hematology, SGPGI, Lucknow. And chairperson is Dr. Mukul Agarwal, Associate Professor, Department of Hematology, AIMS, New Delhi. The moderators are Dr. Devarati Pathak and Dr. Shalini. Webinar hosts are Dr. Anita Borges, Consultant Pathology, Center of Pathology, Tata, Mumbai, and Dr. Sumit Gujral, Professor, Department of Pathology, Tata Memorial Hospital, Mumbai. The main students, please introduce yourselves one by one. Dr. Diljot, introduce yourself.
Good evening, everyone. I'm Dr. Diljot Pannu. I'm a third-year resident, Maharishi Markandeshwar Institute of Medical Health Sciences, Morana.
Good evening, everyone. Good evening, everyone. Myself, Dr. Samangi Valkhade. I am from Weimar Medical College, Tadagaon.
Good evening, everyone. Good evening, everyone. This is Dr. Sushrita Swamprabha from Pandit Jawaharlal Nehru Memorial Medical College, Raipur, Chhattisgarh.
Okay, thank you. Next.
Good evening, everyone. I'm Dr. Yogeshwar, second-year pathology postgraduate from Sri B. M. Patil Medical College, Vijaypura.
Okay, thank you. Next.
Good evening, everyone. Myself, Dr. Helen, second-year junior resident, Tata Memorial Hospital, Mumbai.
Thank you. Next. Any more students? Okay, thank you. Now these are the reminders. The disclaimers. Our next talk is on normal histology and grossing of pancreas by Dr. Ani Samraj on 6 February, 7 p.m. And another one on endoscopic biopsies upper GI by Dr. Ani Samraj.
Can you share my screen?
Yes, sir. Your screen is visible. Just share your PPT. Yeah, make it full screen, sir. Yes.
Okay, good evening, everyone. So today we are going to discuss a few cases of different type of hemoglobinopathy. The basic purpose of this session is to find out how once a patient comes with suspected hemoglobinopathy, how we should approach, what are the different techniques and different modality we can use, and finally how we'll interpret it. So Dr. Diljot, can you explain or answer few of the questions from this first case? Here is a Hplc graph you are seeing on the right.
Yes, sir. So in this, the fetal hemoglobin is 97.3%, which is highly increased, and HbA2 is 2.1%, which is normal. So my DDs would be thalassemia major or hereditary persistence of fetal hemoglobin.
Okay, good. So in this graph, it is not normal. It is absolutely, there is a high fetal hemoglobin, but can it be normal or not? So that is the next question. So the importance is that any of these techniques are not enough to make any diagnosis of any hemoglobinopathies or any thalassemias. So no single technique gives us that liberty to say it is a pinpoint of this particular diagnosis. So we need a lot of things to make a final diagnosis. That is complete blood count with reticulocyte count, what are the RBC indices, RDW, what you are looking in peripheral smear, what type of RBCs you are seeing, are you seeing NRBCs and other, and what are the morphology of that. And then we can use these techniques either electrophoresis or HPLC or capillary electrophoresis. And in case of doubt, we have to do parental screening. And sometimes all these things, even not able to pinpoint the diagnosis, then we need molecular studies also. But what we are missing all over there is clinical history, which is very important. So we should know what is type of severity of the anemia since presentation, whether it is from birth or after few years or days, whether they require transfusion, jaundice, gallstone, intermediate type, or whether they are symptomatic, or what is the family history. So as you told, two diagnoses of that is one is the thalassemia major and other is hereditary percent of fetal hemoglobin. So this is the same graph. On the basis of history, I can tell you so many diagnoses. If I say it is a cord blood sample of a unit, then Dr. Diljot, what is your diagnosis?
The
same HPLC. Yes, so it will be the normal because cord blood contains more than 97% of all blood of is usually mainly fetal hemoglobin only. So it is normal. The same graph, if I say it is 10 month of old baby who is severe anemia and requiring transfusion since age of 6 months. So what will be the diagnosis for this same graph with this history?
Then it would be thalassemia major, as the patient is requiring transfusions.
Yes, so it is thalassemia major, which will be transfusion dependent. Okay, so again, I changed the history a little bit. It is 4-year-old male who is requiring occasional transfusion, one transfusion in last year. So now he is 4 years old and required only one transfusion since birth. So this is the same graph we are getting in this patient also. What would be the diagnosis now?
So then it can be hereditary persistence of fetal hemoglobin.
They are usually, until unless they are deletional type, they are not requiring any transfusion. They are absolutely normal person, even they have more hemoglobin. Okay, so the diagnosis is thalassemia intermedia, which is a syndrome where a lot of different type of hemoglobin come under. And if I say it is an 18-year-old male which is totally asymptomatic, then it is definitely homozygous hereditary persistent hemoglobinopathies. So what are the different modality to estimate these hemoglobin variants?
So first we go with the CBC and the PBF.
So that is okay. Now we are specific to estimate the different hemoglobin variant.
Electrophoresis, hemoglobin electrophoresis, and HPLC, and if we want molecular studies can also be done.
Yes. So the old time still we use this technique of hemoglobin electrophoresis. Here the principle is basically different variant of the hemoglobin have different charges. So on the basis of that we use this property, and when we applied a electric field, these on either on paper or in gel, aerosol, when they applied inside the electric field, they separate. okay, on the basis of their charge. So that can be done either on alkaline pH or acidic pH. But the catch is here, those different hemoglobin variant who has the similar charge, overall charge, they will not get separate. Okay, so like this is your normal, so it will come move here on the basis of their charge and structures. So they are differently moved. So for this technique, usually previously we used to make these agar gel on a slide, then make a bell and then put that hemolyzate in it and put this assembly of electrophoresis and then it will be good. But nowadays we have this automated system which can ready to use gel and you can get a better picture of these separation of these different hemoglobin variant and you can measure it by that instrument also. So as I told that they can be either on alkaline pH, so on that is the most common one where it is separated from A to C, O, Arab, and then ST, that's sickle, T, Punjab, G or Lahore, then fetal hemoglobin, then normal A hemoglobin, and fast moving hemoglobin like J, Meerut and H, etc. The advantage of doing in old time when we are not able to separate S and D, then we use this acidic pH for moving. So the next technique is capillary zone electrophoresis. So capillary electrophoresis is very powerful technique to separate these hemoglobin variant, and many labs are using this technique for analysis of these hemoglobin variant. So to understand how it works, we have to understand how it the principle. So here is the buffer reservoir, and a capillary is connected to this. And in this reservoir, there is two platinum cathode, which is supplied by the high voltage power, and the sample is injected from one side and it is detected on other side. Usually the detector is towards cathode because all the hemoglobin variant they move towards the cathode. So better understanding, we can understand if what is electroosmotic flow and what is electroosmotic mobility. So basically, electroosmotic flow is here the silica, this capillary which is made of silica that is mainly negatively charged, and the buffer who contains both cation and anion. So these negatively charged surface attract these positive anions and they make a fixed layer. Another, there is more, still it is not fully saturated, so more of the cations comes towards this capillary wall. This both layer is called electric diffuse layers. And in the center part of the bulk solution that contains both cation and anion of the same concentration. When we apply the electric field, that is anode and cathode this side, so usually this layer is positively charged. So whatever the concentration over here of negative and positive ions, they move towards the cathode because these are mainly here the maximum part of it is made of the cations. So that is what is electroosmotic flow. The second part of which governs the mobility of these analytes is electrophoretic mobility. It depends mainly upon the charge of the molecule. That is directly proportional and inversely proportional of the size of the molecules, size and shape, and the viscosity of the buffer. So suppose here these are neutral, it is a positive and negative charge. So how they move? So according to the charge of this molecules, they move in this way. This is a cathode and this is anode. So they move according to their charge. So the ultimate when how these molecules move in this capillary electrophoresis. So on the basis of the charges, the electroosmotic flow is always greater than the electrophoretic charge. So whatever movement is there, it towards the cathode. So neutral has no charge, so the ultimate force is electroosmotic force. However, for the positive cations, electroosmotic force as well as electrophoretic charge both will be determined for this. However, these anions they move towards the anode, but as I told, the electroosmotic flow is more than this electrophoretic charge. So ultimately they come towards this side. So what we get over here, the movement of different type of the analytes, they move according to their charge only towards the cathode. That is what I try to explain what is happening inside the capillary zone. So we inject towards the anode, and on the basis whether they are having positive charge or negative charge, ultimately they go towards the cathode, and here they will detect. So in capillary zone electrophoresis, we get these different zones and the separation of these different hemoglobin variant. The most commonly used technique is Hplc, which is cation exchange high performance chromatography. So this is the pictorial representation of how it looks like. So basically here is two phase. One is stationary phase, which is made of silica gels and they are strongly negatively charged layers, and other is mobile phase, which is different type of buffers. So along with the buffer, the sample injected at this side, which is goes through this capillary, and finally on the basis of their charges inside, they will detect it at different time and which convert into a histogram. So let's try to understand what is happening inside this capillary. So this capillary is strongly negatively charged, and at the alkaline pH, the hemoglobin is positively charged. So along with buffer, different type of hemoglobin will pass through this. So these different hemoglobin has different charges of positively charged. So on the basis of affinity, they attach to this negatively capillary, and then when we pass through this low ionic buffer, only which is the weak affinity, they elute first. When we add the other strong buffer, then moderately, and when the totally it is replaced by the strongest buffer, then it will move all the hemoglobin. So that is what we got over here. That's why we get these F as lowest affinity as compared to A2, and then maximum for the A, then maximum for the A2. That's why we get these peak at the different time period. So for Hplc, two things are very important. One is retention time, other is retention window. So what is retention time? Retention time is the time from the injection to maximum peak. So this is somewhere at 2.6 or 7 for A2, A. And retention window when it start appearing and stop eluting. So this is retention window. So that is how Hplc graph looks like. So before interpreting any graph, we should always look this graph very carefully for a few things. Whether these baselines are flat, then what is your retention time of your A2? Then all the peaks, it should not be like A2 comes before A. That means there is something wrong. Then total area, it should be in between 1 million to 3 million. And then your response calibration curve, it should not be on 0.8 and more than 1.2. So that is what we have to look for. And when we try to interpret any type of electrophoresis or Hplc or capillary zone electrophoresis, we always ask a question to ourselves whether all bands we are seeing is expected or there is any unexpected band or peak. So whenever we talk about bands means we are talking about electrophoresis. When we are talking about peaks means we are talking about Hplc. So if it is unexpected peak or band is there, what is the percentage of it? So it was whether we are dealing with thalassemia or hemoglobinopathies, or on the basis of how much this particular type of variant hemoglobin, whether we are dealing with heterozygous, homozygous, or compound heterozygous. So here I want to just clarify that the thalassemia usually like alpha thalassemia and beta thalassemia, where no new band will appears. Whatever A, F, and A2 is there, they either decrease or increase. In hemoglobinopathy like SED, there is a new hemoglobin variant, so a new band or a new peak is appear. So we have to have some room to interpret these things. So this is very favorite slide of Ruchi ma'am. She always say what is normal. So define normal first me. So is it normal or this is normal? So definitely this is abnormal, this is normal. So we should know normal retention time or retention values of different hemoglobin and what is the percentage which we expect in a normal person. So usually less than 5 fetal hemoglobin, A2 is 2 to 3.5, and normal hemoglobin is usually 8 to 90%, and there should be no other abnormal peak. But in abnormal, these varies according to what type of different disease we are dealing with. So that will Dr. Ruchi will cover in next few cases. And especially with the A2, it's very important to see the value. If it is less than 2, then definitely we are dealing with either alpha thalassemia or delta thalassemia, delta beta thalassemia. If it is 7 to 8 or not, it is 4 to 8, then it is heterozygous beta thalassemia. If it is 8 to 15, then definitely heterozygous LEPO. 25 to 30, heterozygous E. And if it is 40 to 50, then heterozygous D Iran. And more than that, then we are dealing with either homozygous or compound heterozygous. So that is how we used to think about these things. So are you able to understand how we should interpret these different techniques which I just discussed? Am I audible?
Yes, sir.
Yes. Yes, sir.
Okay,
Yes.
so I think this is a background which we want to give you before we discuss with the next few cases. So anyone of you can take this case number 2, which is 9-month-old child presented with complaint of pallor and history of recent transfusion 1 month back. On examination, there is mild splenomegaly, and his elder sibling has similar type of complaint of pallor and required transfusion every month. So what information you are getting from this type of history? Anyone can explain? Yes, Dr. Linu? Anyone? Unmute yourself and answer what explain this history. What is the diagnosis or what are you thinking of after seeing this type of history?
So there is probably a hemoglobinopathy because there is history of transfusion in both the siblings. Although the 9-month child has only a single transfusion 1 month ago, but the elder sibling is having transfusions every month. So we can think about some hemoglobinopathy in this.
Okay, so first thing, it is very clear there is a strong history of similar complaint, and the child is presented in early in age. Okay, so it means it is inherited type of disorder. Okay, it is not what we are dealing with the regular any nutritional anemia. Okay, usually we don't get the same type of history. And other thing, it's required transfusion means it is severe. Okay, otherwise till 8 or 7 we don't transfuse the patient, we ask for some oral tablets or something. And there is splenomegaly, which is again point, it is something is there. So what you go for first, RBC indices and peripheral smear. So this is, can you interpret this RBC indices and peripheral smear, and on the basis of this, what will be your differential diagnosis and what the next investigation you would like to do?
Sir, HB is 6.7, that is, it is low. Then CB and MCH is also low. RDW is increased. And on peripheral blood smear, marked anisopoikilocytosis is seen. Then many target cells are seen, and RBC is seen. So this is.
So
So
even if
this
we
is
so even if we calculate
yes,
the Mentor's index, sir, it is also coming.
yes, that is important.
0.7.
Okay,
0.7.
so 6.7 to 4, there is rule of 3.
Yes,
That
sir.
RBC into 3 is equal to your hemoglobin, and hemoglobin into 3 is your hematocrit. So that doesn't fit in this. So usually, especially in the heterozygous conditions of beta thalassemias and alpha thalassemias, that does not fit. But it is not always necessary. If there is concomitant iron deficiency or megaloblastic anemia, okay, then this, or pregnancy or some other liver disease, so then these things indexes are not that good. Especially again in sickle cell anemia, where you usually get normocytic normochromic pictures. Okay, so then these type of rule of 3 will not help you. Yes, but definitely we have to look for this. Okay, I have not given reticulocyte count. So reticulocyte count in this patient corrected retic is 0.5. Okay. So and can you explain the right side picture of peripheral blood picture?
Sir, there are numerous number of target cells. There's a teardrop cells are present.
Yes.
So with occasional NRBCs. Sir, just because
Yes.
Mentor's index is 13.7, still we can go for iron profile of the patient to see if the level of TIBC and the transferrin, even though it is coming like to the point that it is more probably hemoglobinopathy, still we can go for that.
Yes. So always think about common things. So nutritional anemia is very common, but as we have seen in this history,
Yes, there's history
well
of
said.
confusion.
Yes. Yes, so elder sibling has similar complaint, and this child is also classically fitting in cases of where it is presented. Yeah. Otherwise, you have to always start with the if you're seeing for microcytic hypochromic picture, you should think about whether we are dealing with nutritional anemia, and if you rule out, then you should think next. And these things is also indices what you will tell is definitely going to fit. So now, if it is microcytic hypochromic picture, so what could be the differential diagnosis as you told now the history if it is asymptomatic? Okay. So can you read what are the different conditions where you can find these? So usually alpha thalassemia carrier, beta thalassemia carrier, heterozygous ED, homozygous Punjab, delta beta thalassemia, HB LEPO, these can present all these classical RBC indices and microcytic hypochromic picture, but they are not asymptomatic and does not require any treatment. Okay. But if I say these patients are symptomatic, then what will be the differential diagnosis for symptomatic patient who is presenting with microcytic hypochromic anemia and they are not nutritional? What could be? Anyone? Just now you told, na, that thalassemia usually,
Beta thalassemia.
which are the different hemoglobinopathies which can be present with symptomatic transfusion dependent type of, or intermittent or continuous or regular transfusion dependent, are either thalassemia major or homozygous thalassemia, HPS disease, unstable hemoglobinopathies, or homozygous delta beta thalassemia, or different type of compound heterozygous states. So come back to the case. So if I ask these 4 questions, it is suspected case of what?
So thalassemia major.
Yes, thalassemia major.
Major.
And CBC abnormality includes microcytic pictures and severe anemia, anisotropic NPC. So what will be the next step for this?
We can go for sir, HPLC, sir, arms, sir, amplification, reflective mutations, or system for point mutations.
Okay, so usually initial stage we don't do mutation until unless we have some doubt, or we are not able to resolve these things, pinpoint a diagnosis on the basis of HPLC or electrophoresis or capnography electrophoresis. Usually mutational studies done in those cases where it is ambiguity and we are not able to define it, or in cases of prenatal diagnosis, before prenatal diagnosis. But the question is here, suppose this child has received 3 days back or 4 days back transfusion. So can what we are going to get is mix of the disease stage and normal hemoglobin.
Yes, sir, yes.
So what we should do, what a simple things we can do in such case, because we need to treat this child. Okay. So we need a diagnosis to confirm. So what one easy thing we can do to make a simple diagnosis, because whatever HPLC we will do, it's not going to give us a clear picture, because this child has been recently transfusion 3 days back.
So parental screening, sir.
Yes, good. So this is the patient, same graph. Okay, so here it is almost it is what we got, because there is some normal hemoglobin, some A2 and F. Okay, because this has received blood transfusion. That's why this type of picture. So we are not able to justify, because if it is, we are saying it is homozygous beta thalassemia, then it should be somewhere around 97% or 99%. Okay, but it is not. So when we did the HPLC of mother, it is heterozygous. A2 is 5.4, and the father is also having raised A2, which is 4.6. So on this basis, we can make a diagnosis that yes, we are definitely dealing with a case of homozygous beta thalassemia. Is it clear?
Yes, sir.
So in such situation, we can do this thing. So now I just hand over the things to Dr. Ruchi. From here, he will take you in case scenario. Ma'am, are you there? Ma'am, unmute yourself.
Yeah, just a minute. So is the screen visible?
Yes, yes.
Okay, so thank you, Dr. Dinesh, for making my talk simpler. And Dr. Dinesh has actually briefly discussed of whatever common modalities are available routinely in a common hematology lab, which will help you to establish a diagnosis of a hemoglobinopathy. And he has discussed mostly about the techniques and their principles and how do they actually work and help us to establish a diagnosis of hemoglobinopathy. So I'll just take 2 slides to actually say when we talk about a hemoglobinopathy, what are we actually trying to say? So a normal hereditary hemoglobin, we all know, are made up of 2 alpha and 2 beta globin genes, chains, and we can classify them into thalassemia syndromes, where there is a quantitative defect, meaning thereby it can be an alpha thalassemia or a beta thalassemia. When there is a mutation in the alpha globin gene, we call it alpha thalassemia. If there is a mutation in the beta globin gene, we call it beta thalassemia. If there are mutations or loss of the delta beta part of the gene, we call it delta beta thalassemia. So in all of these states, what is happening? The hemoglobin which is formed is normal, but the amount which is produced is reduced. Whereas then we have point mutations which result in variant hemoglobinopathies, which are known as qualitative defects. Here we have examples of sickle, HBD, HBC, and quite a few other lesser known variants. So here what is happening, that we are having an abnormal chain which is being formed because of the point mutation or the mutation, and this comes under basically the qualitative defect. Then there is a third term which we frequently use, that is the thalassemic hemoglobinopathy, meaning thereby that the amount of the protein which is formed is also abnormal and the quality is also abnormal, meaning thereby there is a point mutation, but because of that mutation, the chain which is formed, the protein which is formed is not a very stable protein, hence the protein gets degraded and it is simulating something like a thalassemia. So when we say thalassemic hemoglobinopathy kind of a picture, then probably we are referring to HBE, HB Leopard, some unstable hemoglobinopathies, and hemoglobin constant spring. So leaving aside the qualitative defects, because they'll come to us either in an asymptomatic state, or if we have homozygous sickle, then we'll have accordingly we'll have manifestations which Dr. Mukul can tell us how does he routinely encounter patients of sickle in his OPD. But when we are talking about thalassemia, then on one end of the spectrum we have the thalassemia heterozygous states, that is one of the beta globin gene is affected, and we commonly call them as carrier or trait. Whereas in the other end of the spectrum we have the thalassemia majors, which are both homozygous in state, both the genes are mutated, the beta globin production is markedly reduced or almost absent, and this we call as transfusion dependent thalassemia. And in between these 2 extreme states, we have a condition which is known as thalassemia intermedia, right? So I start from the from the students. So Yogeshwar, how can you tell me clinically how all these 3 differ?
Yes, ma'am. So basically, thalassemia major would be transfusion dependent. The patients would require regular frequent transfusions.
What would be the age of presentation for this such case?
Young patients would be young patients. Thalassemia
How
major.
young? I also consider myself young. How young is young?
Children, basically infants.
Infants. Okay. So there is an arbitrary cutoff, and roughly we say if it is manifesting before 2 years of age, we call it thalassemia major, and 2 years we label it as intermedia. But now broadly the term it is used is either transfusion dependent thalassemia or a transfusion independent, right? Or a non-transfusion dependent basically. So that is about thalassemia major. What about these heterozygous beta thalassemias or the thalassemia carriers? How do they manifest? Yogeshwar, are you there?
Yes, ma'am.
Okay, let us pass on the question to Rajneesh. Okay, then we have Neenu.
Yes, ma'am. Usually the thalassemia at this stage will be asymptomatic.
Okay, asymptomatic. Then how do we identify them? So they are asymptomatic, you correctly said. What would be the first investigation maybe I can tell you from which you can pick up a heterozygous state? Or you can suspect?
We can suspect it through CBC count where the menstrual index will be less than 13.
Okay.
And
Dr. Mukul, after this, can you please little bit explain in broad regarding the clinical presentation how you suspect these cases in your OPD?
So thank you, ma'am. Thank you, Dr. Nish. So what we have now is a classification known as transfusion-dependent thalassemia or non-transfusion-dependent thalassemia. That is the broad term which is used for patients who require transfusions on a 3 to 4 weekly basis. That is classical thalassemia major, or some patients of thalassemia intermedia or compound heterozygous case who require transfusions are like that. This transfusion frequency for the previously called thalassemia intermedia could be up to 2-3 months also, but they are requiring regular transfusions. Otherwise, classically what we call the thalassemia intermedia is those patients they require transfusion during periods of stress, during surgery, during pregnancy, when the normal hemoglobins go down. The classically thalassemia trait are asymptomatic patient, but when you are sitting in a clinic, the picture is not always that smooth. We know that these are always, in many cases, modified by nutritional deficiencies. And as we know that the prevalence of iron deficiency anemia in our society ranges from around 50 to 60%. So this obscures the picture of thalassemia trait or carrier in the CBC. So when we say Menzer index, it's kind of a overhyped index in that regard, because many a times the diagnosis is not very clear. So what we rely in practice is, especially a micro hypo picture, very low MCV and high RBC count, which is not corresponding to that MCV. That is like kind of a clue which helps us in determining whether the patient has thalassemia trait or not. Invariably, in such a scenario, whenever there is slightest bit of confusion, go for both HPLC and serum ferritin test. Remember that iron deficiency anemia is diagnosed on the basis of ferritin, not on the basis of CBC alone. Since iron deficiency is very common, many a times some of these thalassemia trait patients may be requiring transfusions, especially if they are having history of blood losses or otherwise. So, that distinction sometimes becomes obscure in clinical practice. Over to you, ma'am.
Right. Thank you, Dr. Mukul, for summarizing it so nicely. So what I wanted the students just to go back is, and what you have actually brought out is, personally, if you ask me, do I calculate a Menzer index? I say no. There might be people who are more fan of Menzer index, and I have absolutely no objections to that. But there are in India, there is so high coexistence of iron deficiency anemia with beta thalassemia traits that many of the time I would say that you cannot just rely on that index. And as you pointed out, if somebody comes to me with a good going hemoglobin and a very low MCV and an RBC count which is actually going beyond that multiplication rule of 3, we will start suspecting that this is probably a case of beta thalassemia trait or heterozygous beta thalassemia, and definitely put that sample up for HPLC. And I would like to remind everybody, because in the case just before this, the students started talking about the Menzer's index. There, the patient had a hemoglobin of 6.9, severe anemia, symptomatic, requiring transfusion. Menzer index is only for application in a suspected case of beta thalassemia trait who is asymptomatic. So there was no point of discussing Menzer index in that case. जो 6.9 hemoglobin से आया है, अगर उसको थैलेट के साथ कोएक्सिस्टिंग इतना ज्यादा आयरन डेफिशिएंसी एनीमिया हो गया, वो ट्रांसफ्यूजन भी ले रहा है, ये थोड़ा और बात हो जाएगी बहुत, है ना? उस कंडीशन में आई वुड एक्चुअली नॉट लाइक टू अप्लाई Menzer index. You usually apply Menzer index for a condition like this which is asymptomatic. And then again, thalassemia major को आप देखते हो कि usually बच्चा है like less than 2 years of age, or usually they come to you between 6 to 9 months of age, because it is at that time point when the protective HbF hemoglobin levels go down and the beta should have taken its place, but क्योंकि mutation है beta globin gene में, इसलिए normal hemoglobin बनता ही नहीं है, and so they start manifesting usually after 6 months of age, and by 1 year then they'll usually have severe anemia, एक आध transfusion की history होकर के आएगी. And so that for us as a maybe at a tertiary care center, somebody that young who's coming with a history of transfusion and this kind of microcytic hypochromic picture, the first DD would be a thalassemia major. I agree. Sometimes very severely iron deficient patients can also come like this, and the best is कि अगर parents को screen कर लो, like you people discussed, parental screening will give you the answer. So this coming in between to these two extreme spectrums is the thalassemia intermedia. Clinically अगर मेरे पास मुकुल sample भेजेगा कि मैम इसको on and off jaundice है and on and off anemia है, एक blood transfusion इसको 2 साल पहले मिला था और अभी कुछ हुआ है and recently received another transfusion. So I'll put this patient as a broad category of thalassemia intermedia. So that is why do I say thalassemia intermedia is actually a broad category. It is clinically defined कि अगर ऐसा symptom है तो हम सोचते हैं कि thalassemia intermedia है. But genotypically if you see, thalassemia intermedia could be due to multiple conditions. It could be either mutations of both the beta genes, one beta gene and another maybe delta beta or LEPO or deletional HPFH, or there is coexisting of alpha thalassemia, or there is homozygosity of delta beta thalassemia. So the point is that thalassemia intermedia is a term which is used for that kind of a presentation, and genetically and when you do an HPLC, even a HBE beta compound heterozygous can also clinically present as a thalassemia intermedia. So when you have that history in mind, you should have your differentials ready mentally कि ये probably ऐसा कुछ निकलने वाला है. So with that background, if we go to the case 3, we have an 8-year-old male who presented with mild pallor, resident of Bengal, history of transfusion on and off, no significant other family history, and then there is moderate splenomegaly. So Sarangi, can you tell me what would you like to think about it if I say that we have to suspect a hemoglobinopathy?
Ma'am, I would suspect beta thal trait. So it can be HBE or
Sorry, you said beta thal trait and then you said HBE.
Sorry, ma'am. Beta thal trait.
So why would a beta thal trait have a history of transfusion on and off? So the point is not well taken. Traits are usually asymptomatic, incidentally picked up. Majors are those who will be picked up very early in life, right? And when you have such a kind of age, 8-year-old, जो मेरे typical history अभी मैंने बताया आपको दे रहा है कि he has mild pallor, on and off transfusion, and if I say similarly on and off jaundice, so you would probably put the patient as a suspected case of thalassemia intermedia.
Yes,
So then what? And then
Classically जो thalassemia traits होते हैं उसमें organomegaly नहीं होते हैं. So if you're having a splenomegaly, that means some kind of peripheral destruction is going on.
Right. So attack the slide. Okay. So then the CBC findings are hemoglobin. Again, we have moderate anemia, 8.5 hemoglobin. RBC count is on the higher side. Indices are reduced. 63 MCV, 17.5 is the MCH, and 27.7. RDW is high, which is apparent from the smear. RDW is telling you that there is a lot of anisocoilocytosis. We have microcytes, hypochromic cells, and then we have a lot of target cells. NRBC not sure is visible in this field, but these were the findings of this particular case. So if I before we actually go on to think where it is, there's one clue I gave you in the history that the patient was a resident of Bengal. So anybody, Diljot, what is prevalent on the northeastern sides of our country?
HVE.
Yes, very nice. So when you see a case, जो Bengal से आया ऐसी history दे रहा है, तो first thing that come to my mind is suspect ये कुछ E के साथ ही might be unlikely to be a homo HBE, but HBE is definitely high on the cards. This is what my HPLC graph is showing me. So can you continue, Diljot? What is it showing?
So here the HbF is 30.1, which is increased more than the normal, and HbA2 is 51.4.
Right.
So I was thinking of it is a double heterozygous with HBE, HBE Iran, because the HbA2 value is 51.4. So it would lie in the HBE Iran would lie in that category, and along with thal beta.
Right. So so that is one DD. What else comes with A2? अभी हाँ दिनेश ने टेबल दिया था ना कि इतने से ऊपर है कि आप नॉर्मली 8% तक थिंक ऑफ A2 एज बीटा थैल रेट का रिप्रेजेंटेटिव। बियॉन्ड दैट A2 में और क्या कोइल्यूट होता है?
HBD, if it's around 40%, A2 level is around 40%, then we can think of HBD.
हाँ, अभी तुमने मुझे बताया ना पेशेंट बंगाल का है तो तुम कंपाउंड हेटेरोजाइगस
HBE.
ई बीटा क्यों नहीं सोच रहे?
I said E beta initially.
अच्छा, okay, you
Double
said E beta.
heterozygous, HBE
E beta.
gram, and
Right.
E thal B.
So how do we now solve the problem?
And we can also look at the parental HPLCs.
Very good. We can also की जगह ऐसा है कि we have to look. So again we answer these questions after the suspected case of what? What does the CBC look like? What are the HPLC abnormalities? What are possible differentials? And how to confirm this? So thalassemia intermediate clinically by the history, CBC में microcytic hypochromic indices है, so it looks like कि beta thal का component तो साथ में होगा. Then HPLC में we are seeing that A2 is increased and adult hemoglobin is totally absent, indicating that both the beta globin alleles are affected. अगर normal होता कोई भी beta तो थोड़ा बहुत adult hemoglobin बनता, right? So differential diagnosis because of the ethnicity presentation, and I am actually D Iran का incidence कम है. I'm not really sure. Maybe Mukul can say if he has actually seen a compound heterozygous D Iran with beta thal वो clinically कितना manifest करते हैं, I am not sure. But I can tell you that compound heterozygous E beta definitely range from mild anemia to moderate to severe anemia at times of some kind of stress, है ना? So ज़्यादा lab में आपको E beta के patients encounter होंगे ऐसे जिसमें कि F भी इतना ज़्यादा होगा because F is a kind of a compensatory increase for the decrease in the beta globin genes. तो जितना भी alpha बन रहा था वो gamma chains के साथ जाकर के F बना रहा है. It has higher affinity to combine with the gamma globin chains as compared to the HBE mutation के बाद जो बना है. And diagnosis by parental screening, and so the mother is a A2 is
A2 is so thal trait.
yeah. So mother is a heterozygous beta thalassemia and father is a father may I ask Sarangi, what does the father look like?
Intermediate.
Father looks like, what does the HPLC tell you?
A2 is 27.2%.
Right, so A2 is 27.2% and इस A2 region में हमारे पास क्या-क्या elute होता है? HBE, yes, very nice. So the mother is basically a beta thalassemia trait and the father is a likely case of HBE. And why not HBD, Diljot?
For that, the A2 should be around 40% or so.
Right, very good. So अभी मैंने बताया ना because HBE is like a thalassemia hemoglobinopathy. So एक variant बन रही है chain and उसका production भी कम है. तो HBE का heterozygous states में usually it is up to 30%, right? Ideally if you have two chains, you expect कि दोनों beta globin genes से 50% बन रहा होगा. इसमें heterozygous HBE में एक chain mutated है तो 50% abnormal hemoglobin बनना चाहिए था. But लेकिन because E is the protein which is formed is not good quality, it gets degraded. So इसका percentage heterozygous states में it lies up to maximum of 30%. ठीक है, usually हम 25 to 30% के बीच में देखते हैं, right? So we have a diagnosis that the child is a case of compound heterozygous E beta thalassemia, right? So this was an example of thalassemia intermedia, right? Any questions, anybody? Which case solved? Chalo, okay. So Dr. Mukul can say something about how they see E beta thalassemias in their OPD.
So, as has been rightly pointed out, there are several clues. So, E patients, whosoever is either heterozygous or homozygous, they're coming at least some kind of ethnicity is there from the eastern part of India, Bengal or other northeastern states, Assam and other states. All of they have a high prevalence of E. D is slightly more common in the north west part of India, but the prevalence is not very high. Very occasionally, maybe 1-2 cases in a year, the heterozygous or the compound heterozygous D are diagnosed at our center. So it's not very common. But E is pretty very prevalent. Severity, as has been pointed out, so what we characteristically commonly tell our students is that 50% of E beta thalassemia behave like thalassemia intermedia, and 50% they behave like classically transfusion dependent thalassemias. So the severity is moderate to severe in most of the cases.
Okay, thank you. So we move on to the next case. We have a 16-year-old child born of non-consanguineous marriage, resident of Bihar, presented with pallor and jaundice, and there is history on and off of transfusion. The parents again are asymptomatic, and on examination the child had pallor and some hepatosplenomegaly. The counts clearly point out that there is anemia. The RBC count appears to be higher for the degree of hemoglobin, chart 4 into 3, 12. I would expect a hemoglobin of 12 for that count. And then my MCV is on the lower side, and we have a reticulocyte count of 3.5%. So just on the basis of the clinical picture, can somebody say that we are probably dealing again with the case of thalassemia intermedia, right? So मेरा लगता है कि मुझे लग रहा है कि मेरे ही बहुत fascinate करता है ये entity. So we have one more case after that also for this entity only. Okay. So the point is कि again we have a picture which is not severe, thal major नहीं है, asymptomatic नहीं है कोई भी, क्योंकि कोई भी asymptomatic होगा तो आपके पास incidental screening के लिए ही आएगा, आप पिक करोगे. But here we are discussing cases जो symptomatic है and they have come to you for a diagnostic workup. So this is what the HPLC showed us. So for a 16-year-old, we have a F of 100%. So anybody, what would it be? So definitely not thalassemia major, है ना? Major तो बोलना नहीं है इसको because इसका एज नहीं मैच कर रहा. Plus इतना लेट हमारे पास आया है and there is occasional history or there is on and off history of transfusions in the past, right? So what are the differential diagnosis of so much F at this particular age, right? There could be homozygous delta beta thalassemia, delta gene भी नहीं है, beta gene भी नहीं है, इसलिए HbA2 भी नहीं बन सकता और HbA भी नहीं बन सकता. सारा का सारा क्या बनेगा? HbF. और दूसरी कंडीशन क्या है? HpFH. दूसरा क्या है? Homozygous LEPOR. What other compound heterozygous states like delta beta thal or a combination of basically 1, 2, and 3. So clinically, how does homozygous delta beta thal present like? Anybody? I think this will become slightly difficult for the audience which we have over here. So basically, homozygous delta beta thal again comes as asymptomatic to a picture like thalassemia intermedia. Stress हुआ तो he has some degree of anemia. HpFH will patients will be asymptomatic again. They will not come to you for a workup as a case of anemia क्योंकि HpFH में पहले भी बोलती हूँ मार्क की तरह होता है. Fetal hemoglobin is a very protective hemoglobin. So किसी भी reason से अगर HbF किसी का ज़्यादा है तो they are usually their degree of symptoms and the severity of anemia reduces. Then homozygous LEPOR and other compound heterozygous states also present as thalassemia intermedia. So amongst these 1, 2, 3, 4, my likely diagnosis is between except for 2, it could be any of these 3. ठीक है? Is the audience with me? Alvia? Ninu? Ninu?
Yes, ma'am.
Yes. Are you following what I'm trying to teach?
Yes, ma'am.
Okay, very nice. Okay, so how to proceed? So you have a 16-year-old male who is symptomatic and has anemia, has a intermedia like picture, and HPLC already done. अब कौन बताएगा कि क्या करना है आगे? योगेश्वर?
Parental screening.
Very good. मतलब excellent answer. मुझे लगता है कि hemoglobinopathy के लिए कभी भी कुछ भी आंसर करना हो तो हमेशा बोलना चाहिए parental screening. So that is the best answer you should give. And FPC, again, the mother is having a hemoglobin of 11.4 and a father of 13.7. I would say it's kind of asymptomatic, clinically asymptomatic, RBC count higher side for both of them, and you have a microcytic hypochromic picture, not significantly high RDW, and both of them had a F peak of approximately 18%. So what are they probably looking like? You would call them? Diagnosis is? What are the mother and father? What will I call my parents as? We have a F of 18.7%. Anyway, when we have an F of between 5 to 30%, हमारे DDs क्या होते हैं? Heterozygous delta thalassemia and or usually heterozygous HPFH. But अभी मैंने बताया कि HPFH तो symptomatic ही नहीं होते, तो इसीलिए it is quite likely that both the parents are heterozygous delta beta thalassemia and the son is basically homozygous delta beta thalassemia with clinically a thalassemia intermedia-like picture. So based on the clinical findings, the red cell indices and the distribution of HPFH can be done either by the T-Hall test or by FCS on flow cytometry. I would say usually last test अभी हम लोग तो नहीं करते अपने center पर, but this is how traditionally it has been taught to differentiate between HPFH and delta beta thalassemia. So since both the parents are like delta beta thalassemia heterozygous states, so my child is basically a case of homozygous delta beta thalassemia. As a resident मुझे ये term बिल्कुल समझ में नहीं आता था, और जैसे जैसे faculty होने में समझ में आना शुरू हुआ, so maybe I think that even at your level thal trait समझ में आ जाता है, thal major समझ में आ जाता है, thal intermediate समझ में आ जाता है, so it is good enough. But if you can understand delta beta thalassemia, it is basically the green part is basically highlighting that delta beta genes are getting deleted, and same kind of a genetics is involved in HPFH also. But in HPFH, the compensation of the gamma globin gene chain is high, and hence HPFH is usually not that symptomatic, whereas delta beta thalassemias are symptomatic. And usually, if I say microcytic hypochromic indices are found in delta beta thalassemia, and when you do a HPLC in a heterozygous state, they will show you elevated HbF between the tune of 5 to 25 or 30%. ज़्यादा higher रहता है in HPFH as compared to delta beta thal. बहुत सारे तरह के डेल्टा बीटा थैल के नाम दिए गए हैं, घानियन, इंडियन, वियतनामीज, एक्सेट्रा, एंड ये नाम दिए गए हैं ऑन द बेसिस ऑफ द पार्ट और द सेगमेंट ऑफ द जीन व्हिच इज गेटिंग सेक्शन ऑफ द जीन व्हिच इज गेटिंग डिलीटेड. इन इंडिया HPFH3 variant and this Indian variant of gamma delta beta thalassemia or delta beta thalassemia are the commonest. If you still want to, for me it is okay, but if you still want to go ahead and confirm the diagnosis that ये heterozygous compound कि ये homo delta beta thalassemia है, you have genetic marker. What is happening? Your gene is getting it breaks at 2 points, that is over here and over here, and then there is an inversion. That is why the name of the mutation is Asian Indian inversion deletion, and you can run a p-sample PCR and that will confirm your diagnosis. Normally इस extent तक clinical हमको जाने के लिए कम ही कहते हैं, and हम by the parental HPLC and the clinical of the child, we are usually able to establish and confirm that we are likely to be dealing with the diagnosis of Asian Indian inversion deletion, delta beta thalassemia. Case 5, so 16 को मैंने अब 6 कर दिया है मुकुल. So this is a 6-year-old male child born of non-consanguineous marriage, again presented with jaundice. There is history of on and off transfusion even in this child, but it was beyond after 2 years of age, and on examination again the child had pallor and splenomegaly. Again we have hemoglobin of 7.6, some RBC count which is increased, microcytic hypochromic indices and a retic count of 3.5%. Okay, I double हुआ वही हो गया था मुकुल. So this is what the HPLC is telling me. Anybody? कौन बच गया है? Voluntarily आ जाओ. Can somebody read the HPLC for me? No volunteers?
It can be, ma'am.
Yeah, please.
Ma'am, it can be thalassemia trait with a iron deficiency, ma'am.
Thalassemia trait with an iron deficiency के लिए, if you look at this picture only, so there is a history of on and off transfusions and there is jaundice. So थोड़ा सा odd है. Understandably हम साथ में सोचे कि thalassemia trait को साथ में Gilbert's भी हो गया, जो कि एक common association है. Otherwise thalassemia trait जैसा मैंने बताया ना, आपके पास transfusion और splenomegaly के साथ नहीं आएगा, right?
Ma'am, can you go back to graph again? You want to graph again?
Yeah.
Okay, so what is unusual
So,
which you have not seen in previous graphs?
Reintegration.
Anything unusual you are seeing over here?
Yes. कौन बोला सारंगी? नहीं. Who answered?
Bilirubin peak.
Bilirubin peak. Okay, there is a bilirubin peak you can say, but pre-integration peak किसने बोला? अरे सही जवाब बोला बिल्कुल. कोई वो अवार्ड लेने के लिए सामने नहीं आ रहा. Yeah, Neenu. Okay, so these are pre-integration peaks. Very nice. So normally, if you see in the graph which Dr. Dinesh had shown, normally this line is a kind of a flat line. You don't have any peaks between 0 and, or there might be some small peaks, but this kind of a pre-integration peak is usually suggestive of something. But if you also read the graph, आपका F is 0.6% and A2 is 2.1%. What is the normal cutoff for A2?
2 to 3.5.
2 to 3.5. 2.1 is, I would say, on the lower end of the spectrum. So when I have these pre-integration peaks and I have an A2 on the lower end of the spectrum, I should start thinking of
HPH.
very good.
Thalassemia.
Alpha thalassemia, right? So HbH. So why did I put this case again? Because this was also again a symptomatic patient in the terms that he was like a thalassemia intermediate-like picture. So आपके पास कभी कोई patient आता है with this kind of a history of on and off transfusion, some anemia, some maybe gallstones, some splenomegaly. So ये आपके DDs होने चाहिए. You can look at the ethnicity. If you get ये northeast से आया है तो E would come up on your DD. अगर आपका HPLC आगे 2.1 दिखा रहा है and you may or may not sometimes have these pre-integration peaks also, still you should suspect कि HbH disease तो नहीं. So what should be the next investigation? Anybody? What is this?
Reticulocyte preparation.
Very nice. So this is an incubated reticulocyte preparation, and what does it show you? And why are these gall ball inclusions formed?
Beta tetramerase forming inclusion bonds.
Very good. So हमारे पास 3 HbH disease means 4 alleles of alpha chain alpha genes, and when 3 are knocked out we call it as HbH disease. जब 3 alpha chains knocked out हैं तो beta globin chains किसके साथ combine करेंगे जाकर HbA बनाने के लिए, तो उनको क्योंकि कोई नहीं मिलता, so they kind of form tetramers and they precipitate within the cell and they result in the formation of this gall ball inclusions. So this is another simple test which can be done in the lab. जो HPLC नहीं भी करा हो वो भी CBC findings देख करके you should always go ahead and do an incubated retic in that kind of a sample and supplement it with that HPLC finding. We can say that this is the case of alpha thalassemia, and this is how this graph would look like in a case of capillary zone electrophoresis, where there is a separate zone where this Bart's hemoglobin is eluted in HB capillary zone electrophoresis, and it is a better technique to pick up alpha thalassemia sometimes. Get this case worked up, so we were able to show that there is alpha 3.7 deletion and a diagnosis of alpha thalassemia was suggested. Okay, so Dr. Mukul, HbH disease कैसे आता है आपके पास?
Ma'am, this is the classical presentation. So this is a classical presentation which you have discussed. So most commonly it is like this only adolescent or young adults. So they present with intermittent jaundice, occasionally requiring transfusion. Some of them may have higher transfusion requirements also. We suspect
any specific treatment for these patients?
अभी तो कुछ नहीं है मैम, ट्रांसप्लांट या ट्रांसफ्यूजन डिपेंडेंट.
Right.
तो
Okay.
एक इंटरेस्टिंग चीज रहता है, कभी-कभी जो थैलेसीमिया बीटा थैलेसीमिया ट्रेट वाले पेशेंट्स हैं, समटाइम्स इफ दे आर हैविंग जॉन्डिस एंड mild splenomegaly, so that is one condition where they can have a coexisting alpha thalassemia trait also. So that is something which you can just keep in mind, that beta thalassemia trait can be coexistent with the alpha thalassemia as well.
Right. Okay. So then, case 6, we have a 23-year-old male with history of jaundice on and off, and again moderate degree of anemia, some mild microcytic hypochromic indices, and the smear is showing an isopoikilocytes, microcytes, electrocytes, few polychromatophores, and this is what the HPLC is telling me. So, Mukul, तुम भी participant हो क्या?
मैं हूँ।
हाँ. Okay. So Mukul, अच्छा चलो मजाक हो गया. Diljot, can you tell me what is abnormal in this HPLC graph?
A2 concentration is very less. It's 1.6.
Okay. Right. And then what else?
Fetal hemoglobin is 2.3, which is more like 23-year-old male.
Okay. Anything else in the graph?
Anything else? Just initial of the graph. Look
But
carefully.
there's a peak in the pre-integration.
Okay. But अगर jaundice होता है तो bilirubin की वजह से भी ये peak आता है, तो कई बार it is there because of bilirubin also. Anything else? Anybody? Any volunteers?
Another peak corresponding to 2.99.
Yes, very nice. So इसीलिए मैंने वो बोला था, जो दिनेश ने बोला that what is my favorite slide, what is, है ना? So normally आपको A के बाद इस तरह का कोई peak नहीं दिखता है. So at a retention type of 2.99 you have an abnormal peak. Plus if you look at the baseline, this is slightly shifted upwards. Normally when you interpret the graph आपका ये line straight होना चाहिए. So we did rerun the sample and somehow because of this abnormal hemoglobin ये pattern ऐसे ही आ रहा था. And the percentage आपको of this abnormal hemoglobin you can see from here, it is telling you in this graph that there is an unknown peak at 2.99 with a percentage of 7.8%. Right? So we have some variant hemoglobin chain which is eluting at that time point. Normally अब हमारी lab में ऐसा sample आता है तो हमने standardize कर दिया कि हमें next step क्या करना है. Can somebody tell me what is the next step? Can you tell me another investigation which we should do?
Electrophoresis.
Electrophoresis, good, very nice. We should do an electrophoresis. Unfortunately, हमारे पास अभी setup नहीं है तो हम नहीं करते हैं. If there is an alpha thalassemia, we can have some fast moving bands and HB electrophoresis which will come after the adult hemoglobin. What else? Plus, वैसे भी it is a rule when you say that you have some variant hemoglobin, ideally you should show it by 2 tests. But because now HPLC has become such an easy walkaway system कि आप उसको supplement कर लेते हो by a parental screening. So doing those 2 tests is, I will not say that parental screening is a replacement, but yes, it helps you to confirm your diagnosis. So I'll not waste any more time. And the next investigation which we do in our lab is a so again suspected case of आ गया पहले question answer बताओगे तब बताऊंगी आगे क्या टेस्ट क्या करेंगे. So again a suspected case of based on the history that it is not a trait, it is a major, it's falling somewhere in between. Then you have probably a unstable hemoglobinopathy is one differential which we keep here in our lab. Then you have a mild microcytic hypochromic picture. This unstable hemoglobinopathy में alpha mutation या alpha chain alpha thalassemia होने के chances काफी high है because your A2 was low, right? And unstable hemoglobinopathy के लिए या कभी इस तरह का abnormal chain आए, so the diagnosis can ideally be confirmed only by sequencing. But before you go for sequencing, if you are really suspecting an unstable hemoglobin, you should do a heat stability test. And this is a very simple test. Unstable hemoglobin में क्या होता है, alpha और beta globin chains का आपस में interaction is weakened. So what will happen when we prepare a hemolyzate and hemolyzate in a HCl buffer in water bath at 56 degrees centigrade or 50 degrees centigrade, though ये chains हैं, they are unstable and they will precipitate. But normally in a normal adult sample, these chains will not precipitate. So if you see in the control tube, there is nothing here, and then in the test, you can see that there is a precipitate of these abnormal protein. So I'm really thankful to Dr. Dinesh for standardizing this test, and it has actually helped us to pick up and move one more step forward, at least in the diagnosis of some of the cases. And eventually इसके बाद मैं कुछ नहीं कर सकती. It is likely that the parents' sample would come out to be normal. There's one more thing कि unstable hemoglobinopathy में ऐसा लिखता है books कि normally you can how long can you keep a sample before you run it on HPLC or HB electrophoresis? Anybody? आज मैंने sample दिया तो कितने दिनों के अंदर lab को sample run कर लेना चाहिए?
Within a week if it's refrigerated.
Yes. So usually within a week, otherwise you will start getting a high peak of the degraded or the degenerated hemoglobin. So within 7 days, और क्योंकि unstable hemoglobin को लेकर अगर हम कहते हैं 7 days के लिए store किया, so it might get degraded and then you might get a normal HPLC pattern, right? So what we have sometimes now started doing is कि अगर हमारे पास इस तरह का clinical picture आता है और कोई HPLC पे abnormal peak नहीं भी आता है, तो भी clinically if it is being suspected that it seems to be a hemoglobinopathy and we should rule out that कोई unstable तो नहीं है, so sometimes we do subject those samples to heat stability test and we have seen कि हमारा test positive आ जाता है. Which probably suggests, unfortunately, this is not supplemented by a molecular diagnosis in all the cases. That is where you then get stuck and you find it difficult to label. This is courtesy Professor Reena Das' lab. This sample we had forwarded, and this was diagnosed as hemoglobin suntriere, where they worked up the case, and there was a homozygous missense mutation. So this is I have just shown this example to tell you कि HPLC unstable hemoglobinopathies या कुछ hemoglobinopathies में sometimes your graph might be near normal or it might show you just some abnormal peak, and in those cases eventually if you want to actually get a diagnosis, these are those cases जहाँ आपको molecular करना पड़ेगा. D सोच रहे हो, E सोच रहे हो, sickle सोच रहे हो, leopard भी सोच रहे हो या ये तो it might not be mandatory to actually go ahead for a molecular panel, but in such cases you would require molecular testing. So towards the end, so we have spots. Here we have a case where HPLC F is 15% and A2 is 3.4%, when there is a peak of almost 70-80% after A2 at a retention time of 4.3. So diagnosis, Diljot?
Because retention time is 4. I mean, it's after the A2 peak. It can be HBQ.
HBQ के लिए percentage abnormal लेकिन 70-80% HBQ नहीं होगा. HBQ is a beta thalassemia variant or an alpha thalassemia variant? चलो अच्छा कोई बात नहीं. So मैंने एक particular case spectrum नहीं दिखाया मैंने और दिनेश ने, जिसके लिए मुझे डॉक्टर मुकुल ने टोका था. So what do you think this could be? Again, if you look at the plot, there is no normal HbA, है ना? Right? The HbF is increased and then you have a peak after A2 which is a retention time of 4.39. तो E तो है नहीं, right? And I tell you the patient is symptomatic abdominal pain at maybe 7-8 years of age. Right, sickle cell, right? So this is a case of homozygous sickle. A2 अगर sometimes glycated sickle hemoglobin can also come in this A2 region, and suppose ये 4 या 4.5 होता अगर A2 concentration, तो we should have gone ahead and done a parental screening to see whether it's compound heterozygous sickle and beta or is it homozygous sickle. Next plot. Here we have this is an asymptomatic individual with hemoglobin 7.5%. Pregnancy में हमारे पास detection के लिए आया, and you have a peak which is immediately after A2. And because D Punjab starts eluting even before A2 complete हो पाए, इसीलिए frequently D Punjab के साथ A2 is slightly on the lower side. So this is a condition जिसमें आपको साथ में alpha thalassemia नहीं सोचना है, right? इसका clinically if you see a homozygous D Punjab patient would be asymptomatic, and this kind of a test would be picked up incidentally in a lab, maybe a pregnant female who's come for a routine ANC checkup. And this is something we call it very frequently in our lab as the twin tower kind of a thing. What do you think is very good? So this is D Iran, where it is the peak is almost looking like that, similar to the adult A hemoglobin. And why is it not E, Ninu? Why did you not say hetero HBE? No answers? मैंने बताया था ना hetero HBE का percentage is usually below 30%, whereas HBDs के percentage आपके आएंगे between 40 to 50%. So this is the case suspected case of HBD Iran. So I think I'll just quickly sum up. If you have a case who's come to you with anemia suspected hemoglobinopathy, these are the basic investigations which you need to do. Ethnicity is important. Look for sickles. Do a sickling test because your sickle homozygous sickles का भी CBC से कोई clue नहीं मिलेगा. Go ahead and do IB electrophoresis or HPLC or capillary zone electrophoresis, whatever technique is available in your lab. If it is positive, then try and pick up what kind of a diagnosis is likely. Where in the clinical spectrum does the patient come? Is he asymptomatic? Is he symptomatic? Is he requiring transfusions and so on? And then parental screening will eventually give you the clue, right? And if all these are negative, these techniques are negative, but still there is a strong suspicion of a hemoglobinopathy, then sometimes you'll actually have to go ahead for doing a molecular testing. And otherwise, हम molecular testing करते हैं, जैसा दिनेश ने बताया था, for antenatal patients, where we if both the carrier have married, both the husband and wife are carriers, there we need to do antenatal testing, for which we do a molecular testing. That is the last slide, I think. That is the last slide. Okay. So yes, Dr. Mukul, the last words.
last slide एक बार और दिखा दीजिए.
कौन सी?
Last slide.
अच्छा, एक second.
So this is a very important summary slide. So whenever you are suspecting a patient who is presenting with anemia, some organomegaly plus minus jaundice, so it's important to have a look at the clinical history and examination, age of the patient, like highlighted by various examples in the cases. A good preference smear, look at the indices. It's a systematic approach. You need not go for all fancy tests at the first go. You should be able to make a possible diagnosis of hemoglobinopathy from your history, examination, and a peripheral good CBC report. So suspected hemoglobinopathy, go-to investigations are electrophoresis or HPLC in most of the cases. Many a times you are able to you get a patients who have been transfused earlier. So always request your pediatricians, request your clinicians to send a sample for HPLC whenever they are suspecting any kind of hemoglobinopathy before they transfuse. Like it has been said that the sample for HPLC can be kept for around 7 days before it is run. So it's always easier to preserve a sample for HPLC even at night and send it on the next day for testing. Once the patient has been transfused, you miss that opportunity for the classical findings in the case for next around 3 months. Am I correct, ma'am? 3 months at least.
Yes, मतलब 3 months बोलते हैं, but we can try at 1.5 months. और छोटे बच्चों में तो I think हम we cannot really, हाँ, clearance is very low.
Usually we
recommended is 3 months. So what we advise is ideally, but whenever the patient is to be transfused next, you send it prior to it. Okay. So this becomes essential that you take up the sample for HPLC prior you give it transfusion. This is important to teach your clinical colleagues always. Like it is said that most of the cases will be diagnosed through this if they are not transfused earlier. Otherwise, parental screening helps in giving the diagnosis with the characteristic findings. Okay, so this suggests the diagnosis that you're probably dealing with a thalassemia, TDT kind of a thing, that's the transfusion-dependent thalassemia. At times, especially for molecular workup is required for prenatal diagnosis, and some atypical cases in which the diagnosis is not clear. In those cases, you can go for molecular diagnosis. The utility of ARMS PCR is there nowadays. Advent of NGS, you are able to diagnose many more mutations and many such things in it does not go. So, but utilize it very selectively for the diagnosis of hemoglobinopathy. When you have other things in mind, maybe you can send number for NGS. Otherwise, hemoglobinopathy diagnosis can be easily made on the basis of these and parental screening in most of the more than 99% of the cases. Back to you, Dr. Dinesh.
Yeah. So I think Dinesh can take up the questions if there are any in the chat.
Yes. So
And there is some questions.
Yes. So first question is, what is response factor in HbA2 and HbF? So whenever we run the HPLC or any of the analyzer, we usually run calibrators. So the response factor is for calibrator. So calibrator has a particular actual amount of HbF and HbA2. Okay. So what are the actual amount that present in that sample and what your analyzer has been detected? So the ratio of actual upon what has been detected by your analyzer is that ratio is called as response factor. So that should be as close as to 1. Okay, what is there? Like it is some type of resistance material which should be exactly what it should be. So there can be many causes. Either there is problem in the calibration, or there is problem in the cartridge, or there is temperature regulation. So many things can change this response factor. So this is the one way to check that your instrument is working fine. I hope that gave your answers. And other question is, ma'am, kindly explain again a little bit about LEPO. So, can you explain?
Yeah. HbA4 basically is also a kind of a state where HbA2 levels would be high, and roughly in a heterozygous state they will be between 8 to 15%. अगर CBC से हम बात करें, अगर heterozygous LEPO होगा तो वो asymptomatic होगा. CBC wise it will look like beta thalassemia trait. आपके microcytic hypochromic indices होंगे, RBC count increase होगा, alter to near normal, and A2 high होने के अलावा there is a clue in the graph where there is a hump. So I didn't really want to complicate the presentation, इसलिए we didn't put the case of LEPO or show. But if you can imagine a camel's hump, तो उस तरह से when the A2 is above 8%, and if you see that kind of a hump in A2, then you should start suspecting HB LEPO. And a diagnosis के लिए you will actually have to do a molecular. It's a simple gap PCR that will establish the diagnosis. So clinically LEPO is asymptomatic, heterozygous. CBC indices होंगे thalatrate जैसे, और HPLC में मैंने बताया A2 high होगा और एक hump आएगा. And what else? Homozygous LEPO आपका आएगा something like जो delta beta thal homozygous मैंने दिखाया, क्योंकि LEPO में भी delta और beta globin genes दोनों नहीं है, सिर्फ क्या बच गया gamma globin genes, तो वो क्या बनाएंगे खाली HbF. Anything else?
Yes. So next question is, can you clarify between HBD Punjab and SP? So yes, on HPLC usually they are separate because D Punjab usually come retention time of 4.1 and HBS come on 4.5. Okay, so that is the peak which is on HPLC, cation exchange HPLC. It is very clear, but there is problem in when you do it on a capillary zone electrophoresis because they peaks merge. Okay, so sometimes it is difficult on doing on when we're doing on capillary zone electrophoresis, but definitely we, as you see more and more such cases, you come to know which is D and which is S. But when it is compound heterozygous for D Punjab and HBS, then yes, they usually merge.
So again,
So
on
next-
HB electrophoresis also S and D they coalute, so they will migrate in the same region even on HB electrophoresis. And doing a sickling test will help. और दूसरा ये है कि HPLC में नॉर्मली जो सॉफ्टवेयर है उसको रिटेंशन टाइम के आधार पे ऑलरेडी पता है कि मुझे कितने से कितने रिटेंशन पे पंजाब कॉल करना है और कितने रिटेंशन टाइम पे HBS कॉल करना है. And you can, if you still want to do more testing, you can do acid citrate gel electrophoresis जिसमें S और D separate हो जाते हैं. Okay.
So next question is how to report cases when CBC indices are normal and HbA2 value is more than 5%. Would you like or I should give the answer, ma'am?
Dinesh, please go ahead.
So there are some cases where your A2 value is more and it is definitely a beta thalassemia heterozygous, but there is some mutation which does not cause much changes in the indices. So you will not find that microstic hypochromic type of picture in some of these cases. So there is some particular mutation. I don't recall that particular mutation.
Yeah,
And will
that's
that in the promoter region? Yes.
Yes, promoter region mutations में normally आपके indices can be silent, and you are lucky if your A2 is more than 5%, then you can pick up the case. But it is important to pick up these cases also, because if such patients also marry a heterozygous beta thalassemia with some other mutation, the sibling can have a, or sibling can, the child can have a thalassemia intermedia like clinical presentation. तो silent वाले का नाम silent सिर्फ इसीलिए है कि उसकी वजह से indices change नहीं हो रहे, not on the clinical presentation.
So next question, can value of diagnosis for some of the hemoglobin package like lipo, DERN changes the program like D10 and the other variant too? So I don't have much experience on D10. Ma'am has some experience, so please ma'am answer it.
So I remember Dinesh, lepo is also very uncommon hemoglobinopathy, 1-2 cases, but वो जो मैंने बताया हम पता है वो normally lepo में भी appreciate होता है.
They are
So it is
asking
not
about
mandated.
D10, difference between
हाँ,
D10 and variant 2.
भाई D10 पे भी hemoglobin lepo will give you that hump if it is there. And D Iran, I think the D10 is not really programmed to call D Iran, but ये जो twin tower picture जैसा भी मैंने अभी variant 2 का दिखाया, normally D10 पे भी वैसा picture आता है, and people who are seeing D10 or are reporting on D10 are able to pick up D Iran that there.
Okay. So the next question, how to interpret fetal hemoglobin more than 1% in H, and if the HbF normal hemoglobin A is normal. So basically, as I told, and majority of the literature says up till 5% is taking normal. Usually in adult case, we don't see much of the cases more than 1. So some condition where is stress marrow or pregnancy and some small child, this HbF can be more than 1% and less than 5%. So whatever is less than 5%, you have to look for the underlying conditions and patient physiological all these things. Anything else, ma'am, regarding when
नहीं, मेरा भी I think F का cutoff usually I take it till 5%. I believe that there are some stress marrows and stress conditions because of which F can increase. तो कोई मुझे बहुत उंगली करेगा तभी मैं F उतना परसेंट पे वर्कअप करना शुरू करूंगी, नहीं तो ऐसे कि कुछ और ढूंढो जाके.
So next question is what percentage of hemoglobin E is required in electrophoresis to classify as trait? So usually in hemoglobin E heterozygous, we take 20 to, okay, but if it is associated with some alpha thalassemia or some other hemoglobinopathies, then this can be a little bit lower. But usually 20 to 30% of E2 is usually taken as heterozygous E. So better whenever as a pathologist, when we are giving a diagnosis, we should talk about heterozygous, homozygous and compound heterozygous, trait, major, intermediate, these are the clinical phenotype. Next question is, ma'am, why HbA2 is high in Lapo when both delta and beta genes are defective? So, ma'am,
So
please answer.
if it ऐसे वो होता है ना, when you give a topic से पहले तो बता दो कि very nice question, very good question. So actually I would say it's a very good question and I will actually read it up. But जो मैंने थोड़ा बहुत पहले भी पढ़ा है and what I have realized sometimes, I think what might be happening is that the other delta and beta gene, there might be something in the promoter region because of which is the production of the delta chain increase हो रहा होगा, because of which आपका A2 high हो रहा है. So जो deletion हुआ है उसको compensate करने के लिए there is some increase activity in the promoter region. That is one answer I can think of, but I am not sure and I'll actually have to read the reason, true reason behind it.
I will answer it. So the answer is actually they are coming in the same retention window or just before that A2, but actually it is not A2. Okay, if you when I was explaining the principle of these techniques, we told that overall charge may be the same, then they will elute in the same region. Okay, so like E, A2, Lipor, they are all coming in A2 region, but they are not the same hemoglobin variant. So overall charge and the structure are such type, so they have affinity to the negatively charged the surface in silica. It is same. So when the buffer is eluting them, they are coming in the same retention time, same retention window size. That's why they appear at that place, but they are not the same hemoglobin. If you see the structurally, okay, but overall charge and the retention time is same. I hope this will clear your doubt. And I think this is the last question.
Just
Yes,
know
yes.
that what is lipo? It's a misfolded hemoglobin between delta and beta having a kind of a defective hemoglobin which is coagulating at the point of A2. So like Dr. Dinesh said, this is an abnormal hemoglobin cause a fusion of misfusion of delta and beta genes. It is coagulating at the retention time of A2, but actually this is not A2. Okay, so like E is not A2, so E is eluting around the A2 region. So likewise, LEPOR, which is a misfolded protein, it is eluting at the peak of A2. This is not A2.
So the last question is, can you suggest pediatric bioreference interval for the age less than 1 year for the age of HbA and HbF? So there is I don't think till the age less than, yes, for less than 3 months, usually after 6 months, it is comes 3 months over above, it used come as an adult. So more than 6 months, it is as we see in adult, the same percentage of this hemoglobin. But yes, less than 6 or 3 months of age, there will be a little bit more of HbF. So if you go into the literature, you can find, I have not exactly remember this, ma'am, do you remember? But you will find in literature.
Around 3 months of age, we had actually checked again. It comes down to around 20-30% by 3 months of age, and by 6 months of age, it should be somewhere probably less than 10%. ये reference intervals हमको तब जरूरत पड़ती है कि अगर आपके पास कोई बच्चा है जिसका 6 months पे अगर 80% दिख रहा है, then that is abnormal. अगर बच्चा symptomatically anemic है तो. And there is actually a lot of literature available जहाँ बच्चों का sample और reference range दिया हुआ है. At 1 year of age, it is as good as adult, and at 6 months of age, usually your F levels go down to around 20% or even less than that.
Okay, so last question again, it is if HbF value is 3.6 regarding, I think not HbF, they are going to write HbA2. Yeah, so 3.6 as a trait or carrier state. So usually in our lab, whatever comes between 3.5 or 3.6 to 4, we use with match with the missing indices, history and other things, and try to look for whether we are dealing with some type of beta thalassemia or some other things. Ma'am.
Yes, so we have some examples जहाँ पर हमारा A2 3.6 रहा है, तो indices अगर check किया तो they had a megaloblastic anemia coexistent, and it is very well known that megaloblastic can result in a falsely high HbA2 level. So if it is not an emergency, you can tell them to have adequate hematinics and repeat the test. But if it is a pregnant female, I will go ahead and test the husband first, and then ensure कि husband भी carrier नहीं है. और फिर भी अगर husband भी carrier आता है, then I will work up this case further to rule out कि ये carrier है कि नहीं है.
Ma'am, in this case, I also do ferritin because iron deficiency anemia can slightly decrease the HbA2 levels. So that is something which is checked, and just after some supplementation of iron, you can repeat HB.
Yes, that is what. अगर emergency नहीं है कोई तो hematinics खाओ और वापस आओ. लेकिन अगर pregnant female है तो next step 2 is कि screen the husband to ensure that not two heterozygotes who are getting the female is pregnant. तो फिर आपको really आपको TH point है.
No, one of the questions which was asked was
Okay, so all
about
questions are-
when do thalassemia present. So thalassemia trait,
Pardon,
they
madam?
don't present.
Huh.
No, one of the things asked you in this, when do thalassemia trait patient present, or why are they diagnosed? So it's more commonly during pregnancy or when the CBC is done for other indications.
And in
So
our
I think we are
country,
getting
national health mission is just last answer. Why are we picking up carriers? हमारे carrier को पकड़ने का बिल्कुल कोई भी शौक नहीं है क्योंकि वो asymptomatic है. The entire focus is on to ensure कि अगर carrier state है तो is the partner also a carrier or not, and we want to reduce the birth of thalassemia major. That is why we are picking up carriers to decrease the birth of thal major. Otherwise हमें carrier में कोई interest नहीं है management point of view से. I think we will end here, है ना दिनेश? Thank you everyone.
Thank you, madam. Thank you, sir, for this nice presentation.